Well, here we are. I think we are working. And we're actually a few seconds early. And I think the technology is working a bit better this time. Well, there's nothing wrong with the technology. It was entirely me getting it wrong. Okay. Right. So I think we'll just start off. I've had quite a few general questions about this video project and why I'm doing this and how long I've been doing it and things like that. Basically, I started teaching in the early 90s, doing quite a lot of teaching in the early 90s, teaching student nurses. And it seemed quite logical at the time to teach as widely as you could. So I started doing a few podcasts on tape. And then someone suggested I start doing videos because I was interested in working in various parts of the world. I'd worked in some poorer areas of the world before that. And someone suggested I started doing videos. So that's exactly what I did. I started doing these things. Now, if you're young, you won't recognise this. This is the original VHS video cassette. So what we did, we recorded a master one of these. And then we had copies, and but of course it was pre-digital, so you had to keep a master copy and just make one copy, because if you copied copies you would degrade the quality. And then DVDs came along, so we went on to DVDs. I did send some of these old-fashioned tapes to various places. They did get around a bit. And I know for sure they were used in some places. I know they were used in Cambodia, for example, and I know they were used in Ethiopia, which was good, but it was all on a very small scale. But then DVDs allowed for digital copying. But then, of course, things really started to be easier, and the technology was much easier when the digital thing started. And YouTube, I just think YouTube is amazing. It's just an incredible thing. Right, let's see if anyone's actually listening to me. 42 people watching. Okay, well, this is an experimental start, isn't it? So let's see what questions we've got. Now, there are quite a lot of a lot of these questions. There's videos on these topics already on the channel, and every day I get emails from people saying, can you tell me about this, or have you got a video on this? And the answer is very often yes, there is. There's a good few hundred videos on there already. In fact, there's about 500, I think. So what you would do if you go into YouTube and you just go into the YouTube search bar and type in Campbell Teaching, all one word, CAMPBELL, teaching, Campbell Teaching, all one word. Leave a space and then put what you're looking for. And then hopefully it will come up, because you've got to specify the channel and specify the subject. So if you do that, there should be enough to keep most of you amused for quite some time. But of course, the live chat's interesting. We'll see how it goes. Happy is watching from Somalia. Welcome, Happy. That's great to know that people are watching all around the world. It's excellent. Right, so Shahawi Afghan. Would you explain, please, what is pH and why is it important? So that's a physiological question. So I'm now going to try another experimental piece of technology. Let's just see if this works. So I can go on to hopefully that. Yeah, more or less. I think that's okay. So pH, one way to think of pH is the power of hydrogen. We can call it pH. The power of it. pH technically is the negative log of the hydrogen ion concentration. So it's, in other words, the more hydrogen ions there are in a solution, the more acidic that solution is, and that's what an acid is really. It's the concentration of hydrogen ions. And what we have for the pH scale is we have a 1 here, and then we have a 7 in the middle, and then we have a 14 over here. That is the pH scale. Okay. There we go. So that's the pH scale from 1 to 7 to 14. Now, in physiology, it's 7.35 to 7.45. That is the normal pH of the blood. So normal pH of the blood is about here, and we can see it's very finely controlled, very homeostatically controlled. But just by way of background, a pH of 1 is going to be a strong acid like hydrochloric acid, sulfuric acid. The pH in your stomach is probably about 2 because the hydrochloric acid is somewhat diluted. So stomach pH would probably be round about there normally. Very acidic. It's important that it's acidic because that means it will destroy bacteria and things that get in, and that stops us getting food poisoning. So there's a condition called achlorhydria that old people sometimes get where they don't produce enough hydrochloric acid, and they are more prone to gastrointestinal infections. So it's actually very protective. 7 is neutral, so completely pure water. Distilled water has a pH of 7. It's exactly neutral. Quite amazing that water should be exactly neutral in the middle of the scale. So alkali acids here. Then as we go up here, these are bases or alkalines. So the strongest alkaline will have a pH of 14. So something like concentrated ammonia will have a pH of 14. That's one of the reasons that ammonia is so dangerous in the body, because ammonia is NH3. And of course we produce waste nitrogen because carbohydrates are CH and O. Proteins are C, H, O and N. So when proteins are metabolized, the CHO part is used very often, but the N part's left over, and that forms ammonia. That's why it's very important to convert that ammonia to urea in the liver, which is a much lower pH and non-toxic and very soluble. It's very important that human blood is kept at this kind of pH. Now, Aussie Girl's actually asked about blood gases, which we might mention a bit as well. Welcome, Aussie Girl. When we do blood gases, this is the pH in arterial blood gases. Now, the pH in venous blood gases can be different, of course, because that contains more carbon dioxide. And the carbon dioxide will associate with the water in the blood to form carbonic acid. So that's the pH in arterial blood. And that's very important to note, because if it goes below 7.35 down here, then the person is becoming very acidotic. This would be acidosis. Well, not down here, you'd be dead by that time. 7 would be like an unimaginable, inconsistent with life acidosis. But if it goes higher than 7.45, then we would become alkalotic. And both of these are very dangerous pathological situations. So a very good reason for taking blood gases is to get the pH. And the reason that this is so important, and we'll go on to another question in a minute, but we'll just look at why this is so important. Because inside cells, everything works by enzymes. So substance A needs to be converted to substance B. So A needs to be converted to, let's write it over here, A needs to be converted to B. That's going on inside the cell all the time. And biochemical reactions inside the cell don't just happen. The whole thing is amazingly choreographed by enzymes. So that reaction from A to B is only going to happen with enzyme A. Enzyme A. So AAs, if you like, because enzymes end in A's, ASE for enzymes. So that will only happen. And of course, the whole physiology of the cell depends on this biochemistry of the cell. The cell is a biochemical machine, and the physiology of the cell is really arising from the combined biochemistry of the cell. So we need these enzymes. These enzymes are made of proteins themselves. They're complex structures. And if we alter the pH, then that will alter the molecular configuration of the protein. And that will change the shape of that protein. The protein will denature. This is what happens when we cook eggs. If you cook eggs, then the yolk, the albumin, changes and goes white. That's denaturing. And the same thing will happen with enzymes. So an acidosis or an alkalosis will adversely affect the function of the enzymes. Therefore, the biochemistry won't be right. Therefore, the physiology won't be right. And if the physiology is not right, the cell doesn't work. And when physiology is not right enough, that causes death. That causes death. So, for example, the pH could go down with a metabolic acidosis, such as would occur in diabetic ketoacidosis, because the ketones, the two of the organic acids in the ketones are acidic. So that could go down. Or if someone was retaining a lot of carbon dioxide, the pH could go down as well, because, as we've said, that forms carbonic acid. So it just shows how important actually understanding background science is to understanding physiology and understanding that which is normal and that which is abnormal. And that's just one example, that pH. Okay, so let's see how many people are watching now. 46 people watching. Okay, yeah. Now I'm just gonna have a commercial break here. I make a lot of new YouTube videos, and often not many people watch them. And the reason for that is that you have to click the like button, because if you click the like button, that will go up in the YouTube. Whatever the YouTube used to promote your videos, you'll get more people watching if you click the like button. So do click the like button, do leave comments, all that kind of thing really helps. Okay, end of commercial break. Okay, quite a few questions about ECGs. Now, we'll just look at this briefly. Yeah. Now, ECG. So, if we think about the heart, so here we have the heart. So, this is the heart here, and this would be the valves here. And that would be the aorta going out there. The valves on that side, that would be to the pulmonary vessels, the pulmonary artery, dividing into two. Like that. Right. Yeah. Then there's the other valves, the atrioventricular valves there and there. There's blood vessels going in, of course, inferior and superior vena cava. Pulmonary vessels going in there. 4 pulmonary veins. And all this wall here is the myocardium, nice and thick on that side. See how much thicker it is on the left side. Of course, the myocardium there as well. This is the cardiac septum here. And all this is the cardiac muscle, the myocardium. And the only reason that contracts is because it depolarizes. It depolarizes. So an individual cell changes from being negative inside and positive outside, and it changes to being positive inside and negative outside. That's called depolarization. That's what makes it contract, that process of depolarization. Then that goes back round and repolarizes again, ready for the next contraction. So the depolarization in health is stimulated by the muscle contraction in health is stimulated by the depolarization, and that in turn is controlled by the sinoatrial node up there, and the electrical system that goes through the heart, the atrioventricular node, the right and left bundle branches, the Purkinje fibers and branches going off to stimulate the process of depolarization. And to begin with, the atria contract because you want the blood to go from the atria through these valves to the ventricle. That's the first thing you want to happen. So first of all, in the cardiac cycle, the atria contracts, and that gives rise to a P wave. So the P wave is the electrical activity as detected on the surface of the body that occurs as a result of atrial myocardial depolarization. So in other words, what you're seeing is all the atrial myocardium going from that to that, and you're seeing that as recorded on the surface of the body. So the ventricle, the atria have contracted, that's put the blood from there through to there. Next thing we want is for the ventricles to contract, so they're going to contract next. And that means there needs to be depolarization of the ventricular myocardium, and that causes what we call the QRS complex, like that. So the QRS complex is the electrical activity as detected on the surface of the body as a result of ventricular myocardial depolarization. But then, as we've mentioned, the polarized cell has to go back into its the polarized cell. So that's depolarized there. So that depolarized cell. So it's gone from polarized to being depolarized. That process is depolarization. But to contract again, we need to repolarize. So that blue line there represents repolarization. So what you actually see is the PQRS, and then the T wave is actually the repolarization of the ventricular myocardium. Now, of course, there is a repolarization of the atrial myocardium, but that's in there, so you don't see that. It's buried in the QRS complex. So if we just monitor that, that gives us a rhythm. And if we've got a PQRST in the right order and it's regular, then we say that is a sinus rhythm. Sinus rhythm. If there's a PQRST in the right order and it's regular, and the rate is less than 60, we say that is a sinus bradycardia. And if there's a PQRST in the right order and it's regular, and the rate is over 100, we say that is a sinus tachycardia, which are the three normal rhythms. But what we can do is we can look at the heart from different positions. So we can look at the heart from different positions like this. This kind of triangle thing. We can look at the heart from different positions by putting electrodes on different parts of the body, on the legs, on the chest, and that allows us to look at the heart from different positions. So we can end up with leads 1, 2 and 3. So leads 1 will be from the top. That would be lead 1. I think lead 2 is there. Lead 3 will be looking from there. And then lead AVR will be looking from there. Lead AVF looking from there. No, sorry, that's AVL. AVF is down here. So that's AVR, augmented voltage right, augmented voltage left, augmented voltage foot. So we're looking at it from all these different positions. That would be looking at it from there, from there, from there. And then of course we can look at it from the electrodes on the top. So we could have the chest leads. So we could have 1, V1, V2, V3, V4, V5 and V6. So 1, 2, 3 AVR, AVL, AVF looking in this plane, and the chest leads looking in this plane, in this direction, which gives us the 12 lead ECG. So remarkably useful tool. I mean, spent ages at work doing 12 lead ECGs, basically everyone who comes into A&E gets a 12-lead ECG. It's cheap, non-invasive, gives you a lot of information. Okay, there are more detailed videos on ECGs if you wanted to watch those on the channel. Type in Campbell Teaching and ECGs and you'll hopefully come across some. Okay. Any more questions here? Endocrine system. Okay. Pearl is asking about the endocrine system. Okay. Well, there is a whole series of videos on the endocrine system. But we can look at a couple of basic things about it. In fact, I think I might just talk about this one. I think I'll draw a picture. Yeah. So, basically, Pearl, in the body, there's two main communication systems. There's the nervous system, which works very quickly, and there's the endocrine system that works relatively slowly. And the endocrine glands actually produce molecules which are called signal molecules, and they always go into the blood. And that's the definition of an endocrine gland. It's a gland that secretes its product directly into the blood. And that endocrine product is a signal molecule that will circulate in the blood. And it will circulate in the blood, imagine that's the endocrine molecule there. It will circulate in the blood till it comes to a receptor for that particular endocrine product. And once that signal is into that receptor, it's like a lock and a key sort of thing, then that will stimulate a change in the cell. In the cell that has received the endocrine hormone. So, for example, insulin is an endocrine hormone, and it will circulate in the blood until it comes to an insulin receptor. When it binds to that insulin receptor, it won't bind to a thyroid receptor, it won't bind to an hydrocortisone receptor, it will only bind to its own specific receptor. And then that will bring about changes in the cell. And in this case, what will happen, it will cause glucose transporter molecules to rise to the surface of the cell. And that will let the glucose in to the cell. Because otherwise the glucose won't diffuse through the phospholipid bilayer membrane, which is the cell membrane. So it's having endocrine hormones are produced by endocrine glands circulating in the blood and affecting tissues in other parts of the body and regulating and controlling their physiology. That's basically what the endocrine system does. And it's exquisitely homeostatically regulated. So, for example, if your thyroid was a little too high, you're producing too much thyroid hormone, the person would be thyrotoxic and they would be ill with that. Or if they weren't producing enough thyroid hormone, then they would be hypothyroid and they would have adverse consequences of that. Hyperthyroidism, the metabolism would be too high. Hypothyroidism, the metabolism would be too low. And this can be a particular problem in parts of the world where there's not enough iodine, because iodine is needed to make thyroxine. And if there's not enough iodine in pregnancy and childhood, that causes the tragic effects of childhood hypothyroid syndrome with growth and learning difficulties. What used to be called in the old days cretinism, all caused by simple lack of a single nutrient. But it shows how important that the endocrine system is. But there are videos on that. There's a whole series of videos on the endocrine system, starting looking at the pituitary gland, which is divided into two parts. The front part is it's called the anterior pituitary or the adenohypophysis. The back part is the neurohypophysis or the posterior pituitary, and what the different things produce. Absolutely fascinating. amazing way that the physiology of the body is regulated by these endocrine hormones and the homeostasis involved. Everything's just right. It's the amazing thing about life. Everything is just as it has to be. So for example, when we were talking about blood gases, we need the right amount of oxygen in the blood, the PO2, the right amount of oxygen in the blood, and that's detected in arterial blood gases. Or we need the right amount of carbon dioxide, that's CO2. We need just the right amount of those. Because if there's not enough oxygen, that's hypoxemia, lack of oxygen in the blood. That will mean there's not enough oxygen in the tissues. And if there's not enough oxygen in the tissues, that will cause the metabolism in the tissues to change from aerobic metabolism, which is producing energy with oxygen, to anaerobic metabolism, which is producing energy in the absence of oxygen. Now, what is produced as a waste product if the tissues are metabolizing in the absence of oxygen? If there's anaerobic metabolism, what is the waste product that's produced? Well, the waste product that is produced is lactic acid. And we also detect that on our arterial blood samples as it happens. If you want to do it with a venous sample in this country, we send off a grey bottle. I'm not sure what you'll do where you are. But it's one of the parameters that we can test for on arterial blood gases. And if we take serial lactate measurements and we find the lactic acid levels are going up, that means there's more anaerobic metabolism going on in the body, which would indicate that the hypoxia is getting worse, or it would indicate that the tissues are not properly perfused, as in shock. So we would use that observation of the levels of lactic acid in the blood, combine that with other clinical information to give us a trend as to whether our patient is getting better or getting worse, because it's very important in healthcare to monitor trends. Trends are often more important than a single physiological observation. Is it getting better? Is it getting worse? Okay, let's see if I find another question. He was asking about asthma. So it's always nice to talk to an individual. Yeah, okay. Christina, could you explain how to diagnose asthma in primary care? Okay. Yeah, let's have a think about asthma first of all, because we always need to understand a bit about the background. The answer is, of course, there's lots of tests of ventilation we can do. The easiest one actually is, I mean, we can do spirometrics and things, but the easiest one is the peak flow test. You know that one where you just blow in all of a sudden, the peak flow test. And in asthma, that's going to be reduced because there's going to be reduction of the patency of the lower airways. Now let's just have a quick whiz of what that is. So, as you probably know, the bronchial passages keep dividing till we get down to smaller ones called bronchioles. And these bronchioles will divide again into what is called terminal bronchioles. And these will divide again into what are called respiratory bronchioles. And these respiratory bronchioles have small alveolar air sacs in the walls, and they eventually open out into the large alveolar air sacs to provide a large surface area over which gaseous exchange can take place. And if you add all these up, it's about 100 meters square if you're young and healthy. But the air has to get in and out via these smaller bronchioles. So we're talking about the levels of the small airways here. There's no longer any rings of cartilage keeping them open. But the small airways are still too thick to allow gaseous exchange Indeed, the terminal bronchioles here, the walls are still too thick to allow gaseous exchange to take place. It's only when you get down to the respiratory bronchioles here that there is gaseous exchange taking place, where the oxygen can go out there into the blood and the carbon dioxide can get back in from the blood into the alveoli to be exhaled. Now, round about in the bronchioles, there's in the walls there's bands of smooth muscle there like that, because we want to be able to control the lumen of the bronchial passage. We want to allow for bronchodilation and we want to allow for bronchoconstriction. So imagine you're in a situation where you're running for your life. It's a fight or flight situation. Do you want these bronchial passages to be closed, or do you want them to be wide open so we're getting lots of oxygen? Well, I think obviously you want them to be wide open so lots of air can get in, lots of carbon dioxide can get out. And that actually happens. So when there's sympathetic stimulation, that will sympathetic stimulation will dilate the bronchial passages. But then if you're just sitting at home at night in your cave or in your tree or wherever you live when you're in a primitive situation, you don't want these to be wide open. Why don't you want your bronchial passages to be wide open in the evening when you're not doing very much? Well, the answer is that if the bronchial passages are wide open, it's easier for infection to get in. So in that case, we want them to be constricted. We want bronchoconstriction. We want them to be narrow, because we don't want to be breathing in the bugs from the girlfriend or boyfriend next door or whatever it is. So in that case, there's parasympathetic. Parasympathetic stimulation to close those off. So it's important that we do have this elasticity. Now, the background of asthma is that it is an inflammatory condition. I think that's the key thing to grasp about asthma. It's an inflammatory condition. So there's inflammation of these small airways. You tell me, what are the clinical features of inflammation? Heat, pain, redness, swelling. There's not that much space in here actually, so do you think swelling is going to be a problem? Of course it is. The swelling is going to reduce the lumen, isn't it? The lumen is the hole down the middle. That is the lumen. And also inflammation is going to cause the production of lots of mucus. There's going to be mucus production as well. That's why after an asthma attack, and this is actually quite an important indicator, after an asthma attack, the mucus will start being wafted out by the mucociliary clearance system, by all these cilia. And there'll be a lot of coughing in the hours and day or two after an asthma attack, because there's lots of mucus to clear out. So we've got someone has difficulty breathing followed by coughing. But the inflammation also causes bronchoconstriction. So we get bronchoconstriction as well, caused by the parasympathetic effect. So we get swelling, we get mucus, we get bronchoconstriction. That doesn't leave a lot of space left. And what that means as the air goes in and out, and remember this is happening in millions of the similar passages all over, as the air goes in and out, there's turbulence in that air as the air tries to get in and it tries to get out. There's turbulence. Now, when I breathe in, let me go into full screen, show you this. When I breathe in, my diaphragm goes down, my ribs and intercostal muscles go out because the external intercostal muscles pull it out. So inhalation is an active muscular process. So even if the airway is partly obstructed, then inhalation can normally take place. But because breathing out, expiration, is a passive process, it's a passive recoil, it's often much harder to do. So people with this global bronchoconstriction often find it really hard to breathe out, and in fact the whole lungs do become hyperinflated. So instead of the lungs being like this, the lungs will actually become hyperinflated. They'll become fuller than normal. You can't go out that way because the ribs are there, but the lungs become hyperinflated because the patients can't breathe out, and it's a very distressing for them. Of course, they can't breathe out, so they can't breathe in. Horrible condition. So we get the wheezing, we get the dyspnea, the difficulty in breathing. If it's bad enough, we'll get reduction in oxygen saturations. If we take a chest X-ray, we'll see lung hyperinflation. In the time after the asthma attack, we'll get increased production of mucus as well. And sometimes there's a trigger to the asthma. So it could be exposure to pollen or exposure to animals, or sometimes exercise can induce it. There's sometimes a trigger that triggers it as well. But make no mistake, it's a dangerous condition. Asthma is a life-threatening condition. People die from asthmatic attacks. So you would recognise that you would start to become worried if people have repeated episodes of dyspnea, difficulty breathing, followed up by expectoration of mucus. When you auscultate, when you listen with your stethoscope over here, you can hear an expiratory wheeze, or a wheeze which is most marked on expiration. And these would indicate that asthma is a possibility. What I normally do in A&E is immediately give salbutamol. Nebulizers, and sometimes ipratropium bromide as well. Because what the salbutamol will do is it will stimulate the sympathetic innervation of the bronchial passages. And what did we say sympathetic stimulation does to the bronchial passages? Well, it dilates them. So it will dilate them and relieve the symptoms because it dilates the bronchioles, allowing more air to get in and to get out. And because the prime pathology in asthma is inflammation, as we've said, it starts off with inflammation. So the increased mucus, the swelling, the bronchoconstriction are all triggered by inflammatory processes. That's why we often give prednisolone, which is a steroid, after we've given the salbutamol. The salbutamol will work quickly. The steroid will work more slowly, but can be very effective. And the ipratropium bromide will actually inhibit the parasympathetic. That's the way that works. So that's a little bit about asthma. Patient education, very important. They need to take their treaters, the salbutamol, and things like beclomethasone, the inhaled steroids, are the preventers. So, recognise asthma, refer on to someone who can stabilise that condition effectively. Right. Good. Someone listening from Melbourne. Ecgs from Melbourne. That's good. We actually put this on to be somewhat Australia friendly time. It was the middle of the night from when we did the first one in Australia. Okay. So best movie clips watching from Russia. That's excellent. He was a medical student from India studying in Russia. Interesting. People seem to go all around the world to learn to be doctors these days. It's an interesting phenomena. Quite a lot of comments, but not many actual questions. Someone else asking for endocrine hormones, but as we've said, that there are full videos on that, and we have touched on that. Someone says mast cells produce histamine during asthma. That's true. They certainly do, and histamine is also pro-inflammatory and bronchoconstricting. That's what happens with bad anaphylactic reactions. That's the bronchoconstriction is mediated by histamine. So that's a good point. Okay. Mia Her, can you please explain the lymphatic system? Damages. Okay, so okay, we'll have to think about that lymphatic system one. I think before we do that, I'll just we'll have another advert. So if anyone's interested in reading books, so that's one book I've done, the physiology notes. You can still get this in hard copy, but you can also download it from the website now. So the website, let me just tell you the website. The website is the same as the YouTube channel. It's Campbell Teaching. campbellteaching.co.uk, and you can there is a small charge for it, but you can download the e-versions of that. So that was the physiology book, and then what this does is explains normal function, and the pathophysiology book is all about abnormal function. So the idea was that white stands for, I don't know, health, virginity, black stands for disease, death. So there's the white book and the black book. The white book is all normal function. The black book is all abnormal function. And that's not coincidence really. So as I say, you can order those from there in hard copy or soft copy. But the physiology, it's necessary to understand the physiology to understand the pathophysiology, because what pathophysiology is really physiology going wrong. So what I put in those books was what I thought every nurse and doctor in the world should have a bit of an understanding of, really. It's kind of an introductory course. Because it's only when you understand the physiology and the pathophysiology that the clinical features make sense. And of course, it's only when you understand the clinical features that you can make an assessment, make a diagnosis and give appropriate treatment. So it really predicates everything that we do in understanding of physiology and pathophysiology. Because all the care that we give should be based on some kind of evidence. We need evidence. Now, there's not always clinical trial evidence available, so sometimes we have to make the best of our understanding of the physiology and pathophysiology. But if our care is not based directly on empirical evidence, then it should be based on the best available science that there is. One of my particular irritations is when people start making all sorts of health claims that are not based on the science. Really very annoying, because this is people's lives we're talking about. You know, if it's not based on the science, it's not good. Right, so someone asked about the lymphatic system. We'll do a quick go on that. Now, I remember cutting myself once and thinking, oh, that's going to let bacteria win. Why doesn't that cause sepsis? Well, the answer is occasionally injuries can cause sepsis, but thankfully the vast majority of times they don't. And this is the lymphatic system is a major reason why not. So, which way around are we here? Right. So if you think about lymphatics, right. So here we have capillaries. So normal blood capillaries with their cells in the wall. So that's a normal capillary with these little gaps that they have, and the blood is going to go through the capillaries here like this. And some fluid gets out from the arterial end of the capillary, which is good because here we have the body cells which need to be bathed in fluid going through a tissue. That's what a tissue is. A tissue is a group of similar cells with associated connective tissue. So these are bathed in the tissue fluid, and then most of it's reabsorbed at that end. The tissue fluid's reabsorbed, but not all of it. Some is left in there. So what we have is another complete circulatory system. This is quite mind-blowing, but in all tissues there are these, pretty well all tissues. We used to think there wasn't lymphatics in the brain, but in fact we now know there are some. So there's these blind-ended lymphatic capillaries here like this. And these have got floppy cells. So if too much water comes out, that water can go into the lymphatics. Or sometimes proteins can escape into the tissues. And we don't want proteins left in the tissues because the tissues will become too osmotic and swell up. So these proteins can go into the lymphatics. And what this will do, what the lymphatic system will do, is it will drain this away into, so there's another lymphatic capillary there, say. It will drain these away into progressively larger lymphatic vessels. Until eventually some of these lymphatic vessels will drain into a lymph node. So here we have a lymph node like this. So several vessels will drain blood into lymph nodes. And these vessels draining blood towards lymph nodes are called afferent lymphatics. Afferent lymphatic vessels. And they drain this lymphatic fluid. So this is lymphatic fluid that's been collected. The lymphatic fluid moves along. These are contractile to some extent, and that moves the lymphatic fluid into the lymph nodes from all sorts of tissue. So you've got a load of these under your armpit. I don't know, 20, 30 lymph nodes under your armpits, in the groin, various parts of the body, some internal ones as well, associated with the major vessels in the chest, associated with the abdominal organs. But the key thing is in the lymph nodes. There's lots of fine meshworks of reticular tissue, very fine strands of collagen. So it's a bit like a sieve, really. So the lymphatic fluid is kind of sieved through there. And also in here we get lots of white blood cells. Lymphocytes are often associated with the lymphatic system, as the name suggests. And the lymphocytes, what the lymphocytes will do. So sometimes of course, it's not fluids that escape. Sometimes bacteria can escape or get into the tissue. So if you cut yourself, you get bacteria in the tissues, like this. That's what infection is. It's the presence of bacteria in a tissue. And we don't want to leave these here because these bacteria can divide every 20 minutes or every half an hour, causing rip-roaring, life-threatening infections like cellulitis. So what happens is they go through these floppy cells in the lymphatics, and the bacteria are washed away. So the reason I didn't get sepsis when I cut myself was because the bacteria don't stay in the tissues. They go into the lymphatics and they're washed away in the flow of the lymphatics. Usually, hopefully. And when the or if there's viruses get in there as well. And what will happen here is the lymphocytes will recognise the foreign bacteria and will kick off the production of antibody production. So they'll start producing antibodies. The T lymphocytes will stimulate the B lymphocytes to produce the antibodies. And that will combat the infection for us. And also in here there's cells that like eating bacteria called macrophages. And basically, if you're a bacteria, the lymph node is not a good place to be. And then that means so that means that potentially infected fluid can get into there, lymphatic fluid can get into there, but once it's gone through there, it should be sterile. And what happens is eventually these drain back into other, being very diagrammatic here, these drain back into larger lymphatic vessels, and these eventually go up to the actually the junction between the subclavian and the I guess the subclavian and the jugular vein, and they drain the lymph back into the blood around about the level of your clavicle. So this all goes back into the blood here. So the fluid goes full circulation back in. There's a right one of these and a left one of the left lymphatic duct. The left lymphatic duct collects up a lot of lymphatic fluid from the liver and the gastrointestinal tract as well. So we have this complete circulation, but the key thing is that everything drains. This is the key thing about the lymphatic system to grasp. Everything from the tissues drains through the lymph nodes. These lymph nodes are the great guardians and sentinel of the immune system, because there's bacteria everywhere. You go down a kilometre in the earth, there's bacteria. You go up in the atmosphere, there's bacteria. Whole surface of the earth, our skin, the skin of the person sitting next to you is crawling with bacteria. Don't even start thinking about their colon. It's absolutely full of bacteria. I mean, feces is a third dry weight bacteria. The bacteria are everywhere. And yet the tissues of the body are sterile. That is amazing. So like inside my finger there, it's sterile. It's quite incredible. Completely sterile. More sterile than an operating theatre. And that is because the lymphatic system is filtering all the fluid that gets out. And of course, sometimes, unfortunately, these cells here can change to cancer cells. And the cancer cells too will go through these floppy walls and go to the lymphatics. And the lymphatics will slow the progression of cancer. But of course you can't get lymphatic spread because they can start growing in there. So basically, if the lymph nodes are enlarged and painful, that very often means they're inflamed. It's very often infection. But if the lymph nodes are enlarged and hardened and often not painful, then we have to bear in mind the possibility that could be a malignancy. And hopefully the immune system will recognise them as being foreign and eradicate them. If it doesn't, you'll get the disease called cancer. So that's the key to the lymphatic system, I think, is understanding the way they're keeping the tissues sterile. The way the immune system is organised in there. That's the lymphatic system. Okay. Vanessa is asking about hemolytic Anemia. Victor said books are invaluable. Good and easy to understand. Would be called notes for dummies. Okay, I'll accept that, Victor. I'll accept that, thank you. Got to do the simple things first. You can't run before you can walk. No substitute for doing the legwork. Oh, Vanessa's got both books as well. Good on you, Vanessa. Excellent. Yeah. So much easier to download ebooks now. A lot cheaper as well. I think the ebooks are about a third or a quarter of the price. Now you can get them from Amazon, but Amazon take quite a big cut from you and me. And the whole point of this, the books. The books are largely published. I mean, they're peer reviewed, but they're largely published on my own, because if you get involved with publishers, they're not really interested in distributing books to people who need to read them. I actually did a study. I distributed the books in Cambodia, Kenya, and the UK, and then I did a study to see who was reading them most. And after a month of ownership, the people in the UK had spent about an hour or two reading the books, about 2 hours average. It isn't bad. Spent 2 hours reading the books. But in Cambodia, they'd spent about 20 hours reading the books. But in Kenya, the students in Kenya had spent about ages, like 150, 200 hours. They must have read the book a couple of times through in the first month, which of course is the whole point. That's the whole point. We want people that might otherwise struggle to get educational resources to have them. This whole project is really an empowerment project, that people can get this kind of education and apply it to their patients. That's the whole point. And it was interesting. It actually turned out that the people in UK, well, we were just spoiled. We had too many resources and always watching videos on the internet and things for entertainment rather than education. The people in Cambodia also had access to a bit of internet. It was a trial at a particular university that was well supplied with the internet, but the people in Kenya didn't. So they wanted the old-fashioned books, and that's brilliant. That's what it's for. So someone's asking for paper books, no ebooks. You can have the choice, of course. Just that you've got to pay for postage when you send them out. Okay, now who was asking about anemia? Oh yeah, Vanessa was asking about hemolytic anemia. Okay, now it is worth. Well, we have to know about anemia. Anemia is basically a global problem. I can't quite remember the figure now, but it's something like a quarter of the world's population, about 20% of the world's population are anemic. It really is very, very common, and anemia is defined in different ways, but the way I like to define anemia is a reduced oxygen carrying capacity of the blood, when the blood is not carrying enough oxygen to meet the oxygen requirements of the body. And of course that's absolutely essential. And if the blood is not transporting enough oxygen, we call that what do we call that? It's a form of hypoxia. It's a circulatory hypoxia, I think you could call that, or blood-related hypoxia, caused by insufficient oxygen carrying capacity of the blood. So that's what anemia is. It's reduced oxygen carrying capacity of the blood. So in anemia, the red cells are not carrying enough oxygen. These amazing red cells, 5 million or so of these per cubic millimetre of blood produced in the red bone marrow in adults. Darker on the outside, lighter on the inside. Actually, I'll just tell you a trick before we go on. A fascinating trick. You can actually see your own red blood cells if you want. So the way to see them is just look up at a blue sky Well, I mean, in England today it's a bit overcast. Let me just show you outside. We're a bit overcast today. This is typical English weather. Greyish, greyish sky. Yeah. Anyway, that was an aside. So, what was I saying? Oh, yeah. So you can see your own red cells. So look up at the sky and just let your focus fade. Don't try and focus on anything. Just focus on nothing. Or you can try looking at a wall if you want. Just focus on nothing. Or focus. Let your focus. I can't really describe it. Just let your focus go. And then what you start to see is clear little things floating through your visual field. Now, what these are, these are actually red cells going through the capillaries in your retina. And if you kind of notice without looking, you will see that they are like little donuts. And they are your own red blood cells going through your retina. Just amazing resolution of the retina that it can actually see your red blood cells, because these things are small, of course. They're only these are only 7 microns across, 7 micrometers across. Anyway, to get on to the point, anemia. So it can be caused by deficiencies of things. So the most common one, of course, is iron. It could be deficiencies of B12, folic acid. The difference is here that the iron deficiency gives you small cells, and they're faint in colour, they're hypochromic, whereas the B12 and the folic acid give you large cells. So that's the iron deficiency is a microcytic anemia. The B12 and the folic acid are macrocytic anemias, because the lack of vitamin B12 and folic acid means that the DNA is not working properly inside the bone marrow and the cells are too big. So there's deficiencies. We're not making enough red cells, or if there's reduced activity of the bone marrow. The most extreme example of that would be aplastic anemia, where people don't make red cells at all, of course, or white cells, in fact. That's a life-threatening condition. So deficiencies will mean that there's very poor quality red cells. Suppression of the bone marrow will mean that there's lack of red cells. But another possibility is that the red cells are made as normal, but then broken up. The red cells are broken up, and that's called hemolysis. So hemo, H-A-E-M-O. Now, if you're American, I know you don't put the A in, but in England we do. So hemo, blood, lysis means to break up. So whenever you see lysis, that means to break up. So hemolysis or hemolysis means to break up. So what happens is, normally when the cells have lived a normal life, they go to the spleen in the upper left quadrant of the abdomen, and the old cells are broken up in the spleen. They're actually broken up by huge cells, macrophages, which derive from monocytes. So that breaks them up, and the proteins are used again, and that produces the bilirubin, which is a waste product. The bilirubin goes off to the liver, and the liver incorporates the bilirubin into the bile. It goes off to the gallbladder, and then down into the duodenum. after it's mixed up with juices from the pancreas. So normally after the red cells have lived for about 120 days, they're broken up by these macrophages. But sometimes in hemolytic anemia, there's, for example, there's pathological causes of this. So sometimes patients have abnormal cells because they have thalassemia. Or the cells become abnormal because they have G6PD, glucose 6-phosphate dehydrogenase deficiency, that can lead to abnormal red cells. Or sometimes the red cells have spherocytosis. So that's abnormal cells for enzymic reasons, that's abnormal hemoglobin, that's abnormal shaped cells, they're spherocytes. And when the cells circulate to the spleen, they think, just a minute, this cell's got abnormal hemoglobin, or this cell's got G6PD deficiency, or this cell's got spherocytosis. I'll break it up because it's not normal, it's an abnormal cell. So the abnormal cells are broken up by the monocyte macrophage system in the spleen and other places, what used to be called the reticuloendothelial system. And it breaks them up, it breaks too many of them up. So if this is very bad, we get some too much bilirubin, the liver can't process it all, and if it's very bad, we'll get some damming back into the blood. Bilirubin's actually yellow. It only becomes green in the bile ducts because it's oxidized. So oxidized bile is green, the sort that you see if you look at bile. But the bilirubin itself is, that's sometimes called biliverdin, is yellow. So the patient can become jaundiced. And the place you notice that first of all is in the whites of the eyes, if there's any light discoloration there. So that's hemolytic anemia. It's anemias where cells are broken up, and very often it's genetic in cause. But the huge anemia problem in the world is the iron deficiency. So common, and yet so simple to treat. So eating meat, eating liver, although you're not supposed to eat liver when you're pregnant now because of the vitamin A. But offal is very good if you're an adult. Eat offal, eat kidney, eat liver, eat meat, whatever you can afford. You don't have to eat animal products though. You get iron from vegetables. There's iron in it. Vegetarians can get all the iron they need. It just takes a bit longer. But one trick is if you are vegetarian, which of course is good for health for many reasons, it's very good to be vegetarian. Then when you're eating your green vegetables and your cabbage and your spinach to get your iron, drink some orange juice with it if you can, or eat an orange, because the iron from vegetable sources is absorbed much more efficiently if there's vitamin C in the lumen of the gut at the same time. So eat your orange and your greens at the same time and you'll get much more iron absorbed. And we don't normally recommend iron tablets, but they are dirt cheap, and to take a course of iron to bunk your iron up is absolutely acceptable. We use it a lot. Well, that's an hour and 8 minutes. It's actually quite nice. It actually feels more like a normal lesson where you're just sort of explaining things rather than doing things you've prepared. So, right, Razor, 1964. Is that the year you were born, Razor? I don't know. Could be. Why does my skin get thinner as I get old? I'm becoming a withering flower. I'm sure it's not true, Razor. I'm sure you're still in fairly good shape if you're born in 64. Anyway, why does skin get thinner? That's a good question. Let's think about that. I mean, basically, I think what you're asking here is why do people age? What causes the aging process? Well, that's a good question. Let's just look at a few lifestyle things that can affect it. Skin, especially, looks old in people that smoke. So, you know, I see smokers in at work, and they might be in their early 50s and they just look ancient because they've smoked. It really degrades the skin. And part of the reason that smoking degrades the skin is because smoking interferes with vitamin C metabolism. So smokers don't metabolize vitamin C as normal. It's almost as if they've got low-grade scurvy all the time. Now, why is vitamin C so important for the skin? Because in the skin we have all these bands of tough connective tissue called collagen. That's what gives the skin a lot of its body. There's a lot of collagen in the skin. And collagen's a protein, but collagen cannot be formed without vitamin C. So you need plenty of vitamin C to form your collagen. So don't smoke. Do have good nutrition. Do eat a wide variety of fruits and vegetables. That's all going to help the skin. But the main factor causing aging of the skin is the sun. It's photoaging. So the ultraviolet comes onto the surface of the skin. And what the ultraviolet will actually do is it will affect the proteins and actually cause ionization of the proteins in the skin. And they'll get all tangled up. So instead of having nice young proteins like that, they get all tangled up like that. And it all becomes a bit of a mess. So the main advice, I should tell you really, but I've looked after many patients in many intimate circumstances, obviously, and you can get people and they've got very wrinkly, old, horrible, well not horrible, it's just normal, it's just normal aging. You've got normal but old looking, wrinkled up hands, old wrinkled up face, wrinkled up neck maybe, the patient looks very old. But then if you're changing them because they wet themselves or something, sometimes the bottoms are in perfect condition. Got like lily white skin on the bottom and over the gluteal cheeks, in other words. And the reason for that is that they haven't been exposed to the sun. So it's the ultraviolet and the photoaging which degrades the skin. So get good nutrition, don't smoke. And even on an overcast day like today, in the north of England, there's still a lot of ultraviolet actually coming through those clouds. You know, if we had an ultraviolet detector, there's actually a lot of ultraviolet there. So avoiding skin exposure to excessive amounts of sunlight. So that means if you want to, just wear sun cream on your face. That's going to help, or on the back of your hands. Sun cream will protect. Sunblock will protect us from photoaging to some extent. Having said that, of course, especially in northern latitudes, we're chronically short of vitamin D over winter. So what I normally recommend is get, of course you can take vitamin D tablets, of course you can. I think the NICE guidelines allow us to take 25 micrograms of vitamin D per day, which is fine. And there's all sorts of evidence that can reduce diseases, or there's strong intimations that can reduce diseases like type 1 diabetes, multiple sclerosis, colon cancer, pretty well for sure. Immune competence is bolstered by vitamin D, or lack of vitamin D can inhibit immune competence. Cardiovascular disease, all these things. So we need enough vitamin D. So it's good to get a bit of overall sun exposure, but not enough to get burnt. That's my current advice. But of course, sunburn, especially early sunburn, can lead to, or too much sun exposure can lead to melanoma, malignancy of the melanocytes in the upper parts of the dermis. I believe the melanocytes are located. And the thing with that is it metastasizes very quickly. So yeah, vitamin D is important, but too much sun exposure is bad. But a degree of sun exposure is good. So it's kind of balancing that out, really. And the other thing about aging really is, so these things can sort of play around with it. You know, you can look better for your age And it's not just the way you look on the inside, it's the health of the organs on the inside as well, of course. But what you have in the skin, as in other places, are stem cells. Now, a stem cell, for example, the stem cells in the epidermis that will divide to produce the keratinocytes, the cells that produce the top layer of the skin. And these keratinocytes, the stem cells that give rise to, so the stem cells will divide, produce two stem cells. One will stay as a stem cell, and the other will divide into a population of, I don't know, 16, 32, 64 keratinocytes, something like that. But stem cells only divide so many times. And after they've divided so many times, they think, well, that's me, I'm finished. I've done my 100 divisions or 200 divisions or what it is, and that cell will die. So as you age, you end up with less stem cells. Therefore, less viable cells. So in the dermis, you have less viable fibrocytes, which produce the elastic tissues and the collagen in the dermis. As you age, you run out of stem cells in the epidermis, so the epidermis becomes thinner. So it's an inevitable part of aging, unfortunately. There's a few things you can do to tinker with it there. So think about nutrition, think about sun exposure, and certainly don't smoke. It's quite out of the question. Looking for any more questions. Yeah, Bakil, Bakiligiz. Wonder what those things were at the back of the eyes. That's right, they are the red cells. Quite amazing. What is the best component to feed our skin after the age of 30? Well, I think I've already said that. It's just lots of fruit and vegetables and avoiding the sun. Yeah, someone's asking when the next live chat is. I'm actually fairly busy for the next week or two, so hopefully I have one in a fortnight. I mean, if they're going well, plan to have what. Do let me know what the best times for these are. I know we're actually quite early for people in the States at the moment, but good for people in Australia and good for people in India and Africa. So do let me know. But yes, plan on having another one in a fortnight. What I will do is the live chats. What I've learned to do is make like a thumbnail for them, so it will come up and it will say upcoming or forthcoming live chat, and what I'll do is I'll put the times on various places. So I'll put the time in London, Mumbai, Sydney, New York, that sort of thing. A few time zones on it, so you can tune in at the right time. But if they're useful and if plenty of people are watching them, we'll do them. Only 41 people watching at the moment. I suppose that's okay. Fatima asks if you can send some questions. Certainly, but do look on the channel for a lot of things that are there already. Very often people are asking me for videos of things that are already there. So remember, type in Campbell Teaching, type what you're looking for, and hopefully you'll find it. So yeah, there's a guy I've been talking to. I apologise, I can't pronounce your name. I know you're a vet in India though, Dr. Pive. I wouldn't even try. Yuvarajan. You know who you are. Does cooking delete vitamin C? Interesting question. The answer is yes. Heat will degrade vitamin C to some extent. So eating raw foods like tomatoes, oranges, apples, lemons, limes, citrus fruit, potatoes. Although you've got to cook potatoes, haven't you? So this is why I want to eat as wide a variety as fresh food as possible. So basically eat as much fruit and vegetables as you can. But cooking things for long periods of time certainly will degrade the vitamin C. Yes. Yes. Okay, well that's an hour and 20 minutes anyway. I think that's probably enough to be going on with. NSG says, why cystic fibrosis destroys beta cells but not the alpha cells? As far as I know, well, let's think about that briefly. So diseases of the pancreas, like cystic fibrosis or chronic pancreatitis, can destroy the endocrine tissue in the pancreas. That's for sure, and that's why they can cause diabetes. I actually suspect that cystic fibrosis does destroy the alpha cells as well as the beta cells. It's just that you don't notice they're deficient so much. So when you don't produce the insulin, the blood sugar levels will rise because insulin is going to lower blood sugar levels. But glucagon will raise blood sugar levels. But of course, other things do that, like eating and things like that. So I strongly suspect that in fact, I'm pretty sure that the answer is that the alpha cells are destroyed as well when the pancreas is destroyed. It's just that you don't notice the difference. The physiological consequences of alpha cell destruction are not as great as the physiological consequences of beta cell destruction. So people are asking for questions on lots of different things. I mean, okay, it's an infinite process, isn't it? I think the main thing is, you can't know about everything, but the main thing is that if you understand some principles and you kind of know where to get knowledge from, then if there's something specific you need to know for a particular patient, I mean, I get new patients all the time and I think, well, what the heck's this? You don't know much about it. So, but because you've got a bit of background, you understand a bit of the science, you understand a bit of the physiology, you can look it up and you can kind of work it out, and you understand the explanation when you see it. So it gets back to the whole point. There's no substitute for learning the basic physiology and the basic pathophysiology. Okay, so doctor in India again is asking about GERD. A lot of people in India get GERD. Yeah, there's a lot of gastrointestinal problems in India. I tell you what, it's been going for nearly an hour and a half now, so we'll do GERD, and then I think we'll probably leave it at that. So here we have the let's go into the So here we have the esophagus, and here we have the stomach here like this. Then we go on to the duodenum there. So that would be the fundus, the top part of the stomach, the body, the pylorus. So and the diaphragm is about here. It's about there like that. The dome diaphragm. So the stomach's not far below the diaphragm. So what is supposed to happen? And of course, the diaphragm and there's a sphincter there called the cardiac sphincter. So what's supposed to happen is a bolus of food comes down. Here, goes into the stomach, and then that's supposed to close off to stop it from getting back. To close that up, that's the cardiac sphincter closing off. Now, the food then goes into the stomach, waiting to be processed, and it can be there for some time, waiting to be processed. Now, if food goes from the esophagus into the stomach, then that is called swallowing, and that's normal. But if food comes back from the stomach back into the esophagus like that, that's regurgitation. Now, this tube here is called the esophagus in English, but the Americans call it the esophagus. So in England we talk about gastroesophageal reflux disease, and the American nomenclature is gastroesophageal reflux disease. So in England it's GORD, in American medical it's GERD. So GERD and GORD are exactly the same thing. But what's happening is the food is getting back. And of course by the time the food gets back here, it's already mixed with some hydrochloric acid. Hydrochloric acid from the stomach, and also the digestive enzyme pepsin. And that causes a lot of inflammation in the esophagus there. Gastroesophageal reflux disease. And if that goes all the way up, you can taste the acid in the back of your mouth. It actually regurgitates back up. Now, one reason this happens in India, and it's a good reason, is the Indians eat very late at night. So they're very hard working. They'll come in from work about 8-9 o'clock. They'll have a huge meal at 10 o'clock at night, and then they'll go to bed. So that means when they go to bed, the stomach's full. So that means they're no longer in this position. They're now in that position there, like that. They're now lying down, which of course means they don't have gravity holding that down. And if there's a full stomach, any weakness here, then the food can go back up there like that. Of course, if there's a lot of weakness here and a bit of stomach goes up, a bit of the stomach is pulled up through the diaphragm, then that would be a hiatus hernia. So in India, I think the main problem is, I don't think it's the spicy food particularly. I think the main fact is the Indians eat too late at night. So what you need to do is eat earlier. Now I know this because if I eat late at night, I get it as well. So basically, what I try and do is have my tea at about 6 o'clock in the evening. Then you go to bed at 10 or 11, and it's been 4 or 5 hours without eating. Trouble is, I normally feel a bit peckish in the evenings and tend to eat something, but but that's the theory, that you don't eat too late at night. So I think that's the most important reason. Of course, it's very important because this chronic acid reflux over time will cause what we call a metaplasia in these cells that line the esophagus. The cell type will change, and that can cause what we call a Barrett esophagus, and of course that can lead to carcinoma over time. And cancer of the esophagus is very common in India, so it's quite a legitimate point. Good. Spices as the cause, Radio Gaga. Yeah, I don't know. I mean, very hot, spicy food, of course, probably will do, but most Indian food, in my experience, is not full of chili. It's just full of these wonderful flavours. and we know that a lot of these spices, I mean, it's the turmeric, for example, is very good for you, and turmeric's in all Indian spices. Now, I would say don't eat for 3-4 hours before you go to bed and see if that helps. That's the first variable to consider. Okay. Well, I think I'm ready for a cup of tea now. That's an hour and a half, so I think that'll probably do for this one. This is just an experiment. I want to see how these live chats go. It's a different product. It's not the same as a prepared lesson. I've probably said a few things in the wrong order. That happens. But if it's going to work on YouTube, we need lots of likes, we need lots of shares, and that all helps promote the channel, and that hopefully promotes use of these videos in many places. One thing that's really encouraged me in this project recently is the availability of mobile data networks in Africa. A lot more people in Africa are watching, and often people who would find it difficult to access full-time education because it's so expensive. I mean, even in England now, well, it's £9,000 a year to go to university. It's just incredible. We do really need to work out a better way, and this is part of it. Okay, that'll do for now. So the plan is have another one in about a fortnight. I will put a thumbnail up, so you should get a good week's notice or something for the next video that's coming up. Thank you for watching, and God bless you all. And I guess you can watch this again on YouTube if you wanted to watch it again. Okay, bless everyone. God bless you all. Bye.